Great. So thanks again for that introduction. And so I am a dermatologist at MGH, and half my time that I spend in clinic, I take care of patients who develop toxicities to the immunotherapies and to try to keep these patients on the medications that could be life-saving for as long as possible. The other half of the time, we try to figure out, well, how do we even prevent the disease from taking place in the first place to prevent the need for ever going on immunotherapy. And that's really the part that I want to talk to you about today. And if anyone has any questions throughout the talk, feel free to raise your hand. We should have plenty of time. So I receive honoraria from certain pharmaceutical companies and biotech companies, but this is all unrelated to what I'll be discussing today. As all of you know, melanoma is one of the most aggressive forms of skin cancer. It's the 5th most common cancer in the US and represents about almost 2% of all global cancer diagnoses. Worldwide, its incidence exceeds 325,000 cases per year and represents almost 60,000 deaths. The incidence of melanoma has continued to rise, but there's a silver lining now in that the melanoma mortality has started to plateau and even in the last decade started to decline. And we think in large part that's due to the introduction of these immune checkpoint inhibitors for the management of advanced stage disease. Just delving a little deeper, the cancer facts and figures released by the American Cancer Society were just updated for 2024. And we're estimating that about 100,000 Americans will be diagnosed with invasive cutaneous melanoma this year, about 60% of whom are men. The lifetime risk of melanoma has stayed pretty stable at about 3% for Caucasians, 0.1% among blacks or individuals of African ancestry, and 0.5% among Hispanics. And then there's another 100,000 patients who develop melanoma in situ, or the early stage of melanoma that hasn't yet started to invade into the dermis. As I mentioned on the last slide, it is the 5th most common cancer among men, but what's also changed in the last few years is that it used to be the 6th most common cancer in women and is now bumped up to the 5th. So there's an increasing or acceleration of incidence actually among women, and I'll discuss that a little shortly. So the incidence rate for melanoma across both genders has continued to increase by about 2 to 3% annually. And if you take just the decade between 2014 and 2024, that represents about a 32% increase in the total incidence rise just when you compound the incidence rates. This was largely driven by increases in the incidence among women older than 50, even though the highest burden of melanoma is still among men aged 50 or over. Nearly 8,300 Americans will unfortunately die from melanoma this year, with about a 2-to-1 male to female ratio. But again, there is a silver lining in that the mortality rates are starting to decline, and between 2013 and 2017, they fell by about 7%. So the NCCN, which is one of our main staging and guideline mechanisms for disseminating information about how do we approach understanding risk factors, understanding treatments and recommendations for them, has released their updates on what are risk factors for melanoma about a month ago. And most of this is adapted from there, although I took the liberty of adding a couple of others where the literature has been somewhat helpful in suggesting pretty significant associations. These are broadly classified into what we consider host risk factors, or the ones that are unique to the individual, either based on biology or their medical history, and then environmental or exogenous risk factors that are not necessarily a function of the individual, but a function of where they live and their surroundings. So we'll go through most of those in the rest of the presentation. But again, because I'm trying to shift a little bit away from a discussion of UV that has been very thoroughly discussed and most of you are aware of its risk, I'm going to focus more on some of these other risk factors. So let's start with host risk factors. Most of you are probably aware that we typically evaluate melanocytic lesions using this mnemonic of A, B, C, D, E, where we look at the symmetry of the mole or a suspected melanoma, the border, the color variation, the diameter, whether it's above or below 6 millimeters, and whether the lesion is changing over time. Typically, melanomas violate 2 or more of these assumptions, whereas common moles that are completely benign don't violate any of them. These atypical nevi or dysplastic nevi can violate one or more of these assumptions, and they're considered an intermediate stage, and that they're still not malignant, but they're not quite benign. And it's having these types of atypical nevi that is one of the risk factors for the development of melanoma. So I'll give you two examples of what an atypical nevus can look like. Top left, we have a atypical mole measuring about 6 millimeters. It's characterized by some color variation, some border irregularity, and this one is located on the abdomen of an adult. On the bottom, you have a much larger atypical mole. It's about 18 millimeters. It was also somewhat varied in its color and has a little bit of border irregularity. In fact, most people will probably confuse this for a melanoma in situ, given how large it is. And the location here was on the face. So again, a very chronically sun-exposed location. A meta-analysis of 15 studies across the world looked at the risk of melanoma among individuals with different numbers of atypical moles. And they found that if you look at the dichotomous risk, because most patients who have atypical moles tend to have more than one, that the risk of melanoma is about 10-fold higher among those who have these atypical moles than the ones who don't. But if you wanted to count discretely the number of lesions and see how that essentially associates with the risk of melanoma, there's almost a linear increase. With, again, if you have more than five or more atypical moles, the risk is about 10-fold by comparison to those who don't have any atypical moles, but it tends to decrease linearly by number of lesions. A second risk factor that most of you are aware of is just the total number of moles that you have on your body, atypical or otherwise, but commonly just benign. And a separate meta-analysis here identified that patients with more than 100 moles had a nearly 7-fold increased risk of developing melanoma by comparison to patients who had 15 moles or fewer. And this was adjusted for a whole host of potential confounders like chronic sun exposure, acute sun exposure, presence of atypical moles, and family history and genetic predisposition factors. Impact of phototype has been pretty extensively discussed. This is actually a major limitation of how we approach screening patients because we don't have a great way to measure phototype. The Fitzpatrick scale has been around for decades, and it largely is based on an ability to tan or not to tan. So it scores from 1, which is an individual just cannot tan at all and just burns all the time, to 6, where an individual doesn't burn. And individuals who have the highest risk, which is type 1, have a 2-fold increased risk of melanoma by comparison to the next Fitzpatrick type of type 2. If you propagate it out, type 1 Fitzpatrick patients are at about 6 to 7-fold increased risk of melanoma than type 4 Fitzpatrick patients. Eye color and hair color, of course, can also signal the same phototype. So paler hair color or lighter eye color tends to be associated with increased risk of melanoma as well. Overall, melanoma most commonly occurs in older adults, as I mentioned previously, and its incidence rises with increasing age. This figure on the right demonstrates that the peak incidence of melanoma actually occurs among individuals 75 years or older. There's a strong need to continue screening the population even as they get into more older age. And even more striking is how melanoma incidence has increased in the older male population in the last 70 years. This table shows that melanoma incidence has increased 25-fold for men between 50 and 59 years of age, 50-fold for those between 65 and 69, and 80-fold for those between 75 and 79 years in the same time frame. So it's an enormous epidemic among this population. And putting these trends together, we find now that more women are diagnosed with melanoma before the age of 50 by comparison to men, while more men are diagnosed with melanoma than women after the age of 50. And that's depicted in that figure to the right. Also, of course, we do have to keep in mind that outside of just who is at higher risk, men, especially over the age of 50, represent about 60% of more mortality seen in the setting of melanoma. And this is likely because this population has a less likely desire to maybe having a regular healthcare provider. Men don't always listen to recommendations. They tend to receive, less likely to receive routine preventive care and are less likely to participate in cancer prevention programs. So the next risk factor that I wanted to discuss is really personal medical history, which includes a history of blistering sunburns. Though this is a UV exposure-related variable, it is an important one to quantify as it confers pretty significant risk on melanoma development. And on average, a person's risk of melanoma doubles if they have had more than 5 sunburns, regardless of whether the sunburn took place in childhood or adulthood. History of precancers and cancers also increase the risk of subsequent primary melanoma diagnosis. And there are a number of studies that have actually shown this in a validated fashion. Specifically, individuals with chronic lymphocytic leukemia, CLL, have almost a 4-fold increased risk of developing melanoma. Those who have had non-melanoma skin cancers, whether basal cells or squamous cells, are almost 3-fold increased risk. Actinic keratoses, which are these precancerous lesions typically seen on sun-exposed areas, increase the risk of melanoma by about 67%. And of course, if an individual has had one primary melanoma before, they're about 12-fold more likely to develop a new second primary later in their lives. Childhood cancer is actually a pretty important domain that has really been understudied, but the few studies that we do have here show that individuals who have had a cancer early in their lives are about 2.5-fold increased, at a 2.5-fold increased risk of developing cutaneous melanoma. And the cancers that are most likely implicated here are leukemias in childhood, brain tumors, lymphomas, soft tissue sarcomas, and bone tumors. Interestingly, the risk of ocular melanoma was particularly accentuated here, with about a 6-fold increased risk in this population. This one is a little controversial because the studies haven't really been done rigorously, but there has been a relationship between body mass index and melanoma risk. It is somewhat confounded because there are obvious lifestyle factors that may both mediate the relationship between weight and sun exposure and activities outdoors. But a particularly interesting study was performed in Sweden, actually, called the Swedish Obese Subjects, or the SOS study. And what they did is they enrolled individuals with a BMI over 40, half of which went on to receive bariatric surgery, and the other half did not. And they followed this population for 20 years, so a fairly long follow-up. What they found is that the patients who received bariatric surgery had about a 57% risk reduction in melanoma development, and that risk reduction started becoming prominent 4 years after bariatric surgery. Because bariatric surgery is one of the most effective interventions for weight loss, especially in this population, the study authors concluded that there is a very strong, possibly causal link between BMI and melanoma development. Immunosuppression is another very, very important risk factor that often can be overlooked. The NCCN guidelines specifically isolated 3 immunosuppressed populations to focus their recommendations on. The first of these was those people who received solid organ transplants with an increased risk of melanoma of around 2.2. This risk peaked at around 6 to 18 months after transplantation and started falling back down to the rate of the general population at around 12 years after transplantation. Hematopoietic stem cell transplants, so these are typically performed for hematologic malignancies, also increase risk of melanoma, about 5.5-fold increased risk. And that risk is even bumped up further if the patients receive total body irradiation as part of their transplant protocol. By comparison, individuals receiving autologous hematopoietic stem cell transplant still have an increased risk of about 2-fold increased risk of melanoma by comparison to the general population, but it's not as large as for allogeneic. And the HIV/AIDS population really has been pretty extensively studied in their risk of melanoma. But what we found there that was particularly interesting is that in the pre-highly active antiretroviral therapy era, so melanoma risk, while it was elevated in this cohort, was not nearly as high as after HAART was introduced. And the reason why we started seeing that is because HAART really changed HIV into a chronic disease. And as patients began to live longer, their risk of melanoma became more pronounced because it gave them the time to develop the disease. And that risk was around 50% higher. Genodermatoses are a whole host of conditions. The prototypical genodermatosis that is associated with melanoma is xeroderma pigmentosum. It's a rare autosomal recessive genetic disease, and it's associated with defective DNA repair. In a study of about 800 patients with xeroderma pigmentosum, the authors found that this population has up to 2,000 times increased risk of developing melanoma by comparison to patients that don't have this disease. And finally, genetic predisposition really has taken front stage in the last decade, really trying to understand what genes, what germline alterations are responsible for predisposing an individual to getting melanoma. It was found that about 12% or up to 12% of melanomas occur among patients who have either a strong family history of melanoma or an identified germline predisposition. And these were broadly divided into melanoma-dominant germline predispositions, where melanoma is probably the only or the majority of cancers that these patients develop, or melanoma subordinate, where the risk of melanoma is increased, but not increased as much as some of the other cancers that they may be susceptible to. This is a broad list of some of the identified germline mutations associated with melanoma, and they present a different taxonomy of how to think about it. There are the high-risk mutations, low-risk mutations, intermediate risk that also may be associated with other cancers, and then hypothetical risk, but not definitively proven. But what's striking, of course, is that the high-risk variants, the risk of melanoma increases around 50-fold. It's an absolute strong risk factor, whereas with the other groups, the risk is somewhere between 1.9 to 2-fold, except this hypothetical one where we don't yet fully understand it. What's interesting about the high-risk group is that not only are they at higher risk of developing melanoma, they develop it much earlier, typically in the 30s to 40s, whereas the other groups develop it a little bit later, so about a decade later. Still younger than the average of melanoma age of 66. And the other way to look at genetic predisposition is to look at family history. And family history can be among first-degree relatives, so siblings, parents, or second-degree relatives like aunts, uncles, grandparents. What we do find is that melanoma risk is increased if you have either a first or a second-degree relative who has melanoma, although second-degree relatives, that risk is a little bit lower. But what's particularly striking is that if you have 2 or more first-degree relatives who have melanoma, and in total they have about 5 melanomas or more, that risk is pretty close to like 24-fold. Again, pointing at there's probably a germline susceptibility here. This needs to be investigated. We need to find out why so many people are getting it. This is just another way of looking at some of the data I presented on the last slide, demonstrating that if you have a first-degree or a second-degree relative that has melanoma, your risk of melanoma is highest if the person in your family who had it got a melanoma at an age before your current age. So if you're 20 years old and you have a brother who had melanoma when they were 10, your risk of getting melanoma is particularly high. So it's something that we don't always think about in a clinical setting, but it is an important thing to consider. So let's talk about exogenous factors. So tanning beds have been described and discussed very thoroughly as their risk of developing melanoma, and they emit mostly UVA. It doubles the risk of non-melanoma skin cancers, but in the melanoma population specifically, there's a 15% higher risk of melanoma among both men and women who use tanning beds just once in their life. Overall, there's a 75% increased lifetime risk among those patients whose first tanning bed use was before 35 years of age. And if you try to compound the number of sessions that an individual has received in a tanning bed, each session contributes 1.8% to their overall risk of developing melanoma. So and most people don't just do it once, they do it 10, 20, 30, 100 times. So there's been some public health effort to try to minimize this, spread awareness, but I think it hasn't entirely succeeded. Occupational exposures are actually a big area of focus these days because they predispose to not just cutaneous melanomas, but there's some question about predisposing to uveal and even acral lentiginous melanomas. In this particular study, they looked at just cutaneous or invasive cutaneous melanoma, identifying that men who were firefighters had the highest risk, about 2.3-fold increase, and women who were executives had about a 2.5-fold increased risk of melanoma. The mechanisms are entirely unclear, but they suspect that it's because these individuals probably are indoor workers, and when they get their sun exposure, it's high-intensity, intermittent exposure that has been linked to a worse risk of melanoma than chronic low-intensity exposure to the sun. And that has been studied in various settings. Another meta-analysis just confirmed basically that firefighters are a particular increased risk, although maybe not to the same extent as was shown in the last study. And this is thought to be not because they're getting more sun, but they're inhaling or coming in contact with carcinogens. And one of these carcinogens polychlorinated biphenyls, or PCBs, have actually shown a very strong link to melanoma. The odds ratio there is about 6-fold increased risk. And this was actually banned in the US in the 1970s. The trouble is it's still present in a lot of electronics. So when older homes unfortunately get into a fire situation and these products may burn, firemen are there, they have to take care of it and they get exposed. Pilots and cabin crew are also at significantly increased risk of melanoma. And what was interesting is that the risk of melanoma is about the same whether you're a pilot who is sitting in the cockpit versus the cabin crew who are not necessarily in the front of the plane. But the risk of mortality is higher among pilots once they do develop the melanoma than among cabin crew. And one interesting kind of factoid is that at 9,000 meters, which is the average cruising altitude for airplanes, the exposure to UVA is about 2-fold of what it is on the ground. And the glass in the airplanes, whether the window glass or the windshield glass, does not filter most of UVA out. So that's really the mechanism that we think is mediating that risk. Socioeconomic status is an interesting one because it has been linked to an increased risk of melanoma, but I think it's the same mechanism where individuals who are moderate or high socioeconomic strata, they tend to be engaged more in indoor work. And as a result, when they get their sun exposure, it tends to be high intensity, intermittent exposure, causing blistering sunburns that I've shown previously do cause a higher risk of melanoma. But if one develops a melanoma, lower socioeconomic status actually leads to higher mortality. And that's via mechanisms like reduced access to healthcare, for example, poor health literacy, poor ability to surveil one's skin, and ultimately these individuals tend to present to the hospital with more advanced stage disease. So I wanted to finish up by talking about a particular use case of, I've presented quite a few risk factors here, and it's a lot for an individual to really keep in mind. So how do we start approaching synthesizing all of this information together and really coming forward with a plan for personalized medicine where each person, whether they're aware or not of every single one of these risk factors, could be stratified in a more individualized capacity for their risk of melanoma. So one of the things that my lab works on is really using big data, whether it be derived from the electronic health record or large multi-institutional registries to try to risk stratify populations more accurately than what we have done in the past. So this particular study used a weakly supervised machine learning model, and the study is ongoing, but I'm happy to present some preliminary results here, to predict the risk of melanoma at 3 months, 6 months, 9 months, and 12 months following the initiation or the enrollment of an individual into a healthcare system. And here we used the Mass General Brigham healthcare system, which is where I work. We enrolled 22,000 patients. They were split roughly evenly between those who went on to develop melanoma and those who did not. And we used various forms of machine learning approaches, but the one that seemed to perform the best is called gradient boosting approach. And what we demonstrate here is that we reached very high performance of the prediction across all times, whether 3, 6, 9, or 12 months, and that performance was stable both between the internal validation and the external validation of the models. Of course, when we started looking, well, what is driving this performance, it was absolutely no surprise that a lot of this is being driven by family history. I mean, these are proxies for genetic predisposition. These are proxies for maybe even some environmental factors. Certain families may have a greater likelihood to go to the beach every summer than others. But even family history of other cancers like colon cancer, breast cancer, also played a role in this, in increasing the risk, probably pointing to some of these cancer-associated syndromes or mild germline mutations that may confer additional risk. This is an ongoing study, so there's still quite a bit we have to do, not only to refine it and make it more accurate and biologically plausible, but also start thinking about how does one start deploying something like this clinically, and how does one scale this from one institution to another. But the goal of all of this work is, one, to inform all of you, and especially those who are not as informed as you, about what should we be thinking about, what are our risk factors, and ultimately start thinking about how do we triage the right patient to be seen by the right provider early on. Because not everyone needs a dermatologist, and you really need to focus the few resources we do have as a society on screening the ones where we can actually intervene early and maybe save their lives. So I'm happy to take any questions, and really a privilege to speak here today. I'm very humbled by the experiences that you have all shared, and it continues to motivate us every day to keep treating this population and keep finding new ways to help prevent melanoma.
a question for you because you're talking about prevention. Do you have any advice for us? For example, what about our kids? Right? So we all make sure that they're slathered in sunscreen and stay in the shade and those things, but do you have any other recommendations of what we can do?
I think that's a wonderful question, and it comes up all the time, but probably not often enough among some groups. So it depends on if you have had a risk of melanoma or past experience of melanoma, then I think it is prudent to not only get kids into a proactive state of applying sunscreen, learning how to apply sunscreen, because a lot of people apply sunscreen incorrectly. Not enough consistency, it sweats off within 90 minutes, so the reapplication is a big deal. If you go into water, you reapply as well. So I think that's probably the most important thing. But if the family history of melanoma is particularly strong, there is some benefit to getting genetic screening, because it can help inform how frequently your children would have to be seen by a dermatologist, or whether they even need to be seen by a dermatologist in a childhood period. So I think that that's where I would start, just figuring out, is there a strong germline basis to it, or is there not? And if there isn't, maybe get them established with a dermatologist for relatively infrequent visits, but really work on the behavioral modifications. So you can kind of survey your family and see, are there multiple people with melanoma, especially who are closely related, how many melanomas, at what age? I would say if there are 2 or more people in the immediate family, I think genetic screening is something you should discuss with your dermatologist, and they can tell you whether or not it will be beneficial. Especially for those who are still family planning, I think it's a big deal. Yeah. Question? Oh.
I'm coming.
I can hear. I can repeat the question if you want.
Oh, thank you. Hi, I just wanted to ask you, I was at a pediatric summit, melanoma summit, one year. There was a baby there that had been born with melanoma. How rare is that?
It's very unfortunate. It's exceedingly rare. Most of these cases appear either in very large congenital moles, so these are like more than 20 centimeters in the widest diameter at birth, or they can even be leptomeningeal, meaning it's inside the body, which is even scarier. You can't really easily detect that. It's very rare, but it's a devastating disease when it occurs. Yes.
I have acral melanoma, and some of us here have acral and mucosal. We're focusing on the rare ones more. Do we know more about the cause of that? There was a paper I found, theories related to, for example, in Taiwan, there being a greater incidence of people in like fishing and gardening. They did a lot of that. Yeah. Maybe trauma to the hands and feet.
Yeah, it's an active area of investigation because we don't know much about acral melanoma risk factors. We actually have a grant with the MRA and the DoD to study exactly this, and really the whole impetus behind the rare registry was to get a larger cohort to really understand the risks. Some occupational exposures have come out from the earlier studies, so anywhere where you get repeated trauma to the acral locations like the hands and feet, so construction workers, for instance, those who operate heavy machinery. But I think the risks of these melanomas are particularly large among certain ethnic populations, East Asians, for example. There's an increased risk among individuals of African descent, at least by comparison to cutaneous melanoma. So there isn't only an occupational or a behavioral trigger, there is a genetic trigger to this as well. And that's ultimately, I think, going to be a combination of the two, because not everyone gets it and it's so rare. So we have to investigate the synergy of the two.
Sounds good.
Yes.
I think we have time for one more question.
Sure.
To this gentleman.
Yes, in your study there on firefighters, was that a combination of both structural and wildland firefighters? Do you know?
Can you elaborate?
Well, I mean, structural firefighters are those that fight house fires, and you have wildland fires that fight forest fires. And I was wondering if that study had combined those two.
Yeah, I don't think that's a good question. They did not distinguish between them, but based on the risk factors or the carcinogens that they think are implicated, it seems that these are usually from house fires where they get exposed to more of the potential carcinogens in older products that are now potentially banned. However, I'm sure there are components of wildfires or other harmful chemicals that are introduced into the environment as a result of that. It just hasn't been studied distinctively from the rest of the firefighter population.
And I guess the second question is, at what age, for a wildland fire or for a firefighter, at what age do you, is melanoma beginning to occur? When do you see it occur? At what age?
Yeah, so that population is particularly at risk to develop melanoma earlier. Usually it can start in the 30s and increase from there. We actually have an effort by the American Academy of Dermatology to bring volunteer dermatologists to the fire stations because it is very hard to get the firemen to come to us. So we want to go there and we want to screen them on specific days in the year to help see do they have any particular risk factors outside of course of being firemen and firefighters and try to get them into treatment early.
Okay, that brings up a third question that I hadn't thought of. How often would you suggest for a firefighter to see a dermatologist?
I think annually is the minimum.
Annually?
Minimum. Thank you.